on the following topics: subjective, introduction and pathophysiology, utility of diagnostic methods, the prognostic markers, anticoagulations of choice, use of novel oral anticoagulants, role of IVC filters. As I may proceed, my entire webinar will be based on the guidelines as laid down by 2014 European Society of Cardiology, as well as the CHEST guidelines and its update. To start with, venous thromboembolism is actually a combination of deep vein thrombosis and pulmonary embolism. This occurs first time 1 in 1,000 patients, but at the same time, over age of 80 years, the incidence rises. And about 1/3 of patients, they present with symptomatic VTE, present with PE, rest presents as DVT. Although thromboembolism occurs after surgery, but with risk factors like immobilization, cancer, in those patients, 50% cases have no identifiable risk factor. They are termed as unprovoked VTE. If anticoagulant is stopped, then the risk of recurrence is pretty high in such kinds of patients. The recurrent DVT also gives rises to increased risk of post-thrombotic syndrome in 20 to 50% of such patients. Looking at the pathogenesis of this VTE is based on, as we know, the Warfus triad, which is based on alterations of blood flow, vascular endothelial injury, and alterations in the constituents of the blood. Now, based on this, the risk factors can be generated. There are numerous lists of factors that can be found, including some inherited thromboprophilia, as well as presence of a CVC, malignancy, surgery, trauma, immobilization, pregnancy, use of OCPs among the leading risk factors. If the surgical features are concerned, then the risks of venous thromboembolisms are highest in cases of patients who are having more than age of 40 with multiple risk factors, and can be subdivided into highest risk, high risk, moderate risk, and low risk patients. Looking to the second category, the pathophysiology of the pulmonary embolism. This occurs mostly because of starting with the occlusion of the artery, leading to the RV dilatation, increased RV pressure, and entering into a vicious cycle, as we can see from this chart flow, which would, if not, we are able to cut down on the RV dilatation and the right ventricular wall tension, this would lead to activation of the neurohormonal activation, leading to increased oxygen demand, decreased contractility, and entering into the vicious cycle of cardiogenic shock and death. Moving to the clinical features of DVT, mostly they are asymptomatic. If we have the symptoms, then fever is the most common, with the edema as the most specific sign. Cough pain, we can elicit with Homan sign, pain provoked on dorsiflexion of foot or by the Moses sign. But while executing such signs, we must take care of to avoid the dislodgement of an acute thrombus as well. Other two signs are Neuhoff signs, Linton signs. Moving on the clinical decision rules, there is a score which is called a DVT score, which is actually based, as we can see, on the important clinical variables depending on the risk factors and the different signs and symptoms that we have just studied. And depending on that, I can grade the DVT as moderate likelihood of DVT, less likelihood of DVT, or high likelihood of DVT. If I need to study about the clinical features of PE, in case of embolism, the most common symptom is a dyspnea, with the most common sign as a tachycardia. And another thing to keep in mind, pulmonary embolism should always be ruled out whenever there is any case of unexplained dyspnea. Signs, tachycardia, tachypnea, low-grade fever, hemoptysis, they may also be associated. The diagnostic criteria on the pulmonary embolism is the famous Wells criteria. That has similarly, as per the DVT score, probability on based on the presence of the clinical symptoms as well as the clinical predilections of having high probability of PE if the score is more than 4 based on this Wells criteria. We have, for the sake of our diagnosis, as per the American Heart Association, we have divided this pulmonary embolism into massive, submissive, and mild. In case of mild, there is an acute PE and absence of clinical markers. In case of submassive, without any hypotension, but with either RV dysfunction on echo or clinical criteria of myocardial necrosis, which can be shown by the TROP-I, TROP-T, or BNP. In case of massive PE, there should be sustained hypotension, there should be pulselessness, or persistent profound bradycardia. Utility of the different diagnostic tests. ECG changes. ECG changes, the sinus tachycardia is most common, and such type of ECG changes are most prominent while ruling out a PE, which we must take care of whether there is any complete, incomplete RBBB, RV strain pattern, right axis deviation, dominant R wave, P pulmonale. But the most specific finding is simultaneous T inversion in inferior leads and right precordial leaves. I will show some of the ECGs that shows the tachycardia RBB with T wave inversion, which is a diagnostic of clinical pulmonary embolism. Next is the D-dimer assay. D-dimer's levels are elevated because of the reason simultaneous activation of coagulation and fibrinolytic cascade occurs in DVT and PE. It has a high negative predictive value of D-dimer, means if D-dimer is less than normal, PE is actually excluded. But if D-dimer is in positive, there is a suspicion of PE, but it may not be PE because D-dimer can be falsely raised in presence of malignancy, inflammation, trauma, bleeding, post-surgery, including a large number of cases. At the same time, we need to adjust the cutoffs based on the age. If I see the chest radiographs, though these signs are not seen nowadays because of the advent of the much MDCTs and the other scans, but these are the counter signs of pulmonary embolism, like the Westermarck sign, as I can see on the X-ray, or the Hampton's hump, which has a sensitivity of 22% and the specificity of 82% if they can be detected on the X-ray. MDCT or the pulmonary angio nowadays is an investigation of the choice. It has an overall sensitivity and specificity of as high as 83% and 96%. Thus, negative MDCT is adequate for excluding PE in non-high clinical probability. But there is a twist. If the patient is having segmental or subsegmental clause, maybe additional testing is required. Like I can see in these CT images, the embolus can be easily visualized. Another is a VQ scan. VQ scan is necessary when specifically diagnosing PE in cases of pregnancy where the MDCT cannot be done. There are three categories of reporting in VQ scan. This may be normal, where PE is excluded. This may be high probability, which is considered diagnostic for PE, and non-diagnostic scan. It's safe to withhold anticoagulant therapy if I have a normal VQ scan. This is the frames from the VQ scan, where on the left-hand side, I have the normal scans, while on the right-hand side, I have the high probability scan showing the presence of pulmonary embolism. If I do the echocardiography, I should look into the RV dilatation, increase in the diameter ratio, if hypokinesia, increased velocity of tear jet, decreased TAPC. Negative predictive value for pulmonary embolism in echocardiography is as high as 40 to 50%. And echocardiography holds the most important role as clinical diagnostic value when the patient is unstable and I am suspecting a PE, where unequivocal demonstration of RV overload and dysfunction can help me to start the emergency reperfusion therapy because the patient is too unstable to undergo MDCT angio. Compression ultrasonography, this is with respect to the DVT. This was found to be very useful with a sensitivity of 90% and specificity of 95%. But one main thing is that in cases of compression ultrasonography, while doing that, I should compress the vein in up to that much of pressure, which I need to compress the aorta surrounding it. And at the same time, I should take care of it that it doesn't dislodge and already form thrombus over there. If I look as per the 2014 European Heart Association guidelines. These are the diagnostic criteria, and based on such criteria, I can actually differentiate my pulmonary embolism suspicion into low, intermediate, high, unlikely, and likely, and decide on or move ahead with the emergency management. In cases of high-risk patients, as per the guidelines, this has been taken that CT angio, if immediately available, go for it. If that is not, echocardiography is as good as. If I am finding a RV overload on echocardiography, I should go ahead with the reperfusion therapy or the specific management of PE. If I have positive with CT angio, obviously I should go ahead with the reperfusion therapy if available. Or if it's negative, I should try with other causes. If my patient is PE with shock and hypotension, if my patient is without shock or hypotension, but I am suspecting a PE, then I have a utility of D-dimers, which D-dimers, if positive, I should go ahead with CT angio if available and confirm. Otherwise, if I am getting likely to be PE, I can go straight ahead to the CT angio. This is the severity index that gives us a prognostic markers that the presence of the factors with pulmonary embolism would classify it into a moderate mortality risk, low mortality risk, and help us to prognosticate the patient. This prognostic course, as laid down by 2014 ESC guidelines, and also as well as the CHEST guidelines, they have given us that prognosis score is based on this PACE as in high, intermediate, low, and PACE class 3, 4. If they are present, they are helps us to prognosticate the patient. Before management, I would like to focus on the differential diagnostics that we need to keep in mind while treating such patients. They include pleurisy, costochondritis, pneumonia, bronchitis, asthma, COPD, MI, pericarditis, CCA. Management, first is definitely on the following topics: oxygenation, hemodynamics. They are the basic rule for management of any critically ill patient admitted at an intensive care unit. Followed by for PE, anticoagulation, NOACS, thrombolysis, thrombectomy, IVC filter. Avoid hypoxia in any cause and maintain the hemodynamics by modest volume administration. Vasopressors, there has been no consensus on what vasopressors or inotropes to initiate with, but we mostly go ahead with norepinephrine, followed by dobutamine to increase the cardiac index, and the levosimendan if I am suspecting any to increase the RV pressures or specifically the pulmonary compliance as well. Anticoagulation, the heparin is the cornerstone. Heparin, a bit about its polysaccharide sulfation, actually binds to the enzyme inhibitor antithrombin 3 and causes a conformational changes with selective activation of its activating factor. Heparin inactivates the coagulation factors 10, 9, 11, and 12. And we need to keep a target EPTT 1.5 to 2 times the control. Shorter half-life of heparin is very advantageous because often such patients need to be surgically thrombectomy or undergo insertion of filter or the reperfusion therapies. We can initiate the unfractionated heparin via intravenous. This is on the base of Rashkin homogram as follows. Other than heparin, the low molecular weight heparin can also be used. They are monitored by anti-factor 10 ASA, measuring the anti-factor A activity. They binds to antithrombin 3, but they inhibit the factor and has got no factor on inhibition on factor 2 and only inhibit the factor 10A. If I compare the unfractionated and low fractionated, the most significant variation of low molecular weight is its predictable response, whereas in case of unfractionated heparin, there is significant protein binding, inactivation by platelet peptide probe. So they gave an unpredictable response. Another is more bioavailability of low molecular weight. They have a longer half-life, so they are actually pretty suitable in intensive care units, and it doesn't need any regular monitoring. And also, the important thing is that the risks of heparin-induced thrombocytopenia is significantly less if I use LMWH. The different LMWH has been stated here, like the enoxaparin, dalteparin, and their doses at an interval. And as we can see, the doses are mostly once a daily to twice a daily doses, which is very convenient. Monitoring, plasma protein level useful is monitoring is even is needed to be. Most cases it doesn't need. only the conditions where it needed to be LMWH dosing in obese patient with renal dysfunction, and if I am determination of the origin of an unexpected bleeding or clotting problems in patients receiving what appropriate to be an anticoagulant dose, only in few cases as well. Another coming is a FONDAPARINUX. This is an anticoagulant pentasaccharide that specifically binds to factor A and neutralizes the factor 10A by antithrombin. It has a once daily dosing, which is very much essential with low creatinine clearance patients. Its uses, they can be used as initial treatment of acute PE and acute DVT, management is suspected of proven HIT, or they may use as monotherapy without warfarin to treat the VTE patients as well. Moving to the warfarin, the vitamin K antagonists, they prevent the gamma carboxylation activation of the coagulation factors. Half-life of the factor 7 is 6 hours, while half-life of factor 2 is 5 hours. But one thing about warfarin is that the full anticoagulant effect of warfarin may not be apparent by initial 5 to 7 days because they need that time to actually deactivate the already present coagulation factors. And for this reason, while initiating warfarin, a bridging therapy with heparin or the LMWH is extremely essential. For VTE patients, the target INR with warfarin should be 2 to 3. This bridging therapy, the warfarin should be overlapped with LMWH to counteract this progulant state that we has already discussed. The starting dose, one of the study has shows that warfarin can be started as 5 mg versus 10 mg in the VTE patients, and they has given no changes in the mortality rates. Moving to the newest, the new oral anticoagulants. Vitamin K antagonist has been the mainstay of management of thromboembolic events for more than 5 decades. But they have significant limitation based on their increased drug interactions and the necessity for regular monitoring of PT-INR. On the background of this, novel oral anticoagulants have significantly taken up the places. They can be available at parental as well as oral, and they are similar. Established anticoagulants are the argatroban, bivalirudin, and dabigatran, rivaroxaban, and the newer one, apixaban, egrotroban. So here we can see the FDA-approved indications of rivaroxaban, apixaban, dabigatran, and edoxaban has been the VTE in all of them. They has been first approved following the surgical patients, and they also need to be bridged upon with the parental anticoagulant treatment on the initial 5 to 7 days. Alternatives to heparin, these novel oral anticoagulants has been undergoing different trials like RECOVER trial, Einstein trial, Amplify trial, and all of them have showed excellent efficacy outcomes whenever they are used in the recurrent VT or in VT or in PE. Newer factor 10 inhibitors, some of the newer of them are the betrixaban, YM150, TAK442. This betrixaban has a unique features of a 15-hour half-life and extra-renal clearance. These are undergoing the phase 3 evaluation, and TAK442 is undergoing the phase 3 evaluation for ACES patient as well. Monitoring is mostly not needed. Even if we need it, we can monitor it with PT, EPTT, and thrombin time, but they are very difficult and they actually do not need to be monitored routine cases. Reversal agents with NOACS, this is also the one of the cases that 3 new reversal agents has been tried, which are adnexacate alpha, idarucizumab, and PER977. Adnexacate alpha is a recombinant modified human factor 10A that is developed as direct factor 10A reversal agent. They rapidly attenuate the anti-10A activity of all the 4 commonly NOACS and restore the thrombin generation in phase 2 studies. Mostly well tolerated, they are undergoing the phase 3 clinical trials. Idarucizumab is a humanized antibody of the FACT that binds with dabigatran only. It rapidly reverses the anticoagulant effect of a 220 mg twice daily dosing of dabigatran in healthy human volunteers. Third one is a PER977. This is a water-soluble small molecule, and this has been undergoing preclinical testing based on eroxaban reversibility property. Important thing is the duration of the anticoagulants. If it's a case of first provoke PE, the duration is recommended 3 to 6 months. If a first provoke upper extremity DVT, 3-6 months. If it's a second, consensus are very uncertain, but most likely should be of indefinite durations. If there is associated malignancy with this, consider indefinite duration until the cancer is resolved. If it's a case of unprovoked pre-E, the definition as we have stated that in more than 30% of the cases, no predisposing risk factors has been evaluated for DVT. Consider indefinite durations. First, unprovoked cup DVT 3 months. Second, unprovoked should be uncertain. In cases of cancer and VTE-induced DVTs, LMWH can be used as monotherapy. But in provoked or proximal leg DVT, anticoagulation for indefinite range with INR targeted as 2 to 3. Recurring VT, this has a high fatality rate, especially when it occurs despite ongoing anticoagulation within first week of diagnosis. Even after completion of a 6 months cases, the case fatality rate of PE in recurrent cases are pretty high. The risk factors we need to isolate, they are while anticoagulants are being taken, increasing age with the background of elderly patients, immobilization, cancer, COPD, right ventricular enlargement or right ventricular dyskinesia, risk factors are increasing. After anticoagulants are discontinued, the risk factors as overweight, presenting symptoms of PE, low levels of HDL cholesterol, lack of leg main recanalization increases the risk of recurrent venous thromboembolism. Now the thrombolysis. Early thrombolysis, obviously, it's the cornerstone because it helps in reduction of the PO pressures and the improvement of the RV function. Within 48 hours of benefits, it gives the greatest, but it may be extended up to 2 weeks depending on the individual case scenario. The indication most important is any kind of unstable PE or in patients of intermediate high risk who has developed signs of instability while under observation, go for thrombolysis. But they have in intermediate risks, in hemodynamically stable patient, we need to depend on the case-to-case individualized scenario. Approved agents for thrombolysis includes the streptokinase, urokinase, and RTPA. And the doses are as follows. In case of streptokinase, 20 million international unit as a loading dose over 30 minutes with followed by 1 lakh international unit per hour over 12 to 24 hours. So with urokinase and renectaplase. Contraindication of thrombolysis, we should keep in mind the absolute are hemorrhagic stroke or stroke of unknown origin at any time, ischemic stroke in the preceding 6 months, central nervous system damage or neoplasm, recent major trauma, surgery, head injury in the preceding 3 weeks, GI bleeding within last month, no bleeding risks. Relative contraindication, transient ischemic attack in the preceding 6 months, oral anticoagulant therapy, pregnancy, non-compressible puncture site, traumatic resuscitation, refractory hypertension among the relative contraindication. Surgical embolectomy, we may need to proceed with that also. In hemodynamically unstable patient, selected intermediate high risk patient, particularly if thrombolysis has failed or is contraindicated. Before thrombectomy, normothrombic CPB should be initiated, and this can be done till the segmental level only. 2 operations like the palm operation and May-Hasni operations has been deviated for this. If I see about the clinical suspicion of PE, whether I need to differentiate whether shock or hypotension is present or not. If shock hypotension is present, go with that earlier year, go with CT angio. If shock hypotension is present, go at least do an echo. If there is RV dilatation, and just classify it into high risk, intermediate risk, and low risk patient, and get the prognostic variations done on based on PACE score. Then consider for either reperfusion or observation, or consider it's a low risk patient, consider early discharge and observations at home only. If it's a high risk patient, CT angio is immediately available, you can go for it. But if the patient is too unstable, just do an echocardiography, check out the RV overload, and diagnose as whether they suspected PE based on the PACE score, get it classified into high risk, intermediately slow risk patient, and initiate the treatment management as discussed. These are the guidelines. Similarly, as stated, when my patient is in shock hypotension, what should I do? And when my patient is without shock and hypotension, I can go ahead with the observation and do a CT angio for my better guidance. For the role of IVC filters, this is usually deployed in the infrarenal IVC, and for deployment of IVC filters, the other leg should be there's a right leg, or if the DVT is in left leg, the right leg should be clear of DVT because it needs to be introduced in the infrarenal portion of the IVC. Indications: patients with absolute contraindications to anticoags, patients with proven recurrent PE despite demonstration of adequate anticoags, and IVC filter decreases the risk of PE recurrence at the cost of increased incidence of DVT. These are the insertion of the IVC filters that has been implanted. Nothing is without complications. So IVC filters also comes with some complication, as there may be recurrent DVT, there may be post-thrombotic syndrome, there may be occlusion of IVC, filter migration, tilting, deformation, fragment embolization, and device thrombosis. Looking at the summary of the treatment recommendation, it has been, these are the class 1 recommendation where it has been stated, as per these are taken from the ESA guidelines and the CHEST guidelines, that intravenous anticoags with unfractionated heparin should be initiated without delay in patients with high-risk PE. Thrombolytic therapy is recommended. Surgical pulmonary embolectomy is recommended for patients in whom thrombolysis is contraindicated or has failed. We have just discussed them. If my patient is without shock, initiation of parenteral anticoags is recommended without delay. LMWH or FONDAPARINUX is the recommended form of acute-phase parenteral anticoags. In parallel to parenteral anticoags, treatment with VTE or the vitamin K antagonist is recommended with a targeting INR of 2.5. On the new oral coagulations, oral anticoagulation, the class 1 indication is as an alternative to VTE, we may try with rivaroxaban, apixaban, or the dabigatran, and the edoxaban, and all of them holds the class 1 indications. For the IVC filters, they should be considered in patients with acute PE and absolute contraindications to anticoagulations. IVC filters should be considered in case of recurrence PE, but they hold a class 2A level of recommendation. A special factor is the PE in pregnancy, because PE in pregnancy is the leading cause of maternal mortality in developed nations. Risk of PE is higher, particularly after a cesarean section. Dyspnea as a symptom is not useful. D-dimer is naturally elevated, so it's very difficult for us to get the PE diagnosed on the basis of D-dimer alone. Radiation exposure is also there, so VQ scan is probably more helpful. Like we can see, if I'm suspecting a suspected PE, I can go with the leg symptoms, do a compression ultrasound. If it's positive, I should go ahead with treat. If it's positive, the chest X-ray can be done, but this is not when the patient is pregnant, then I can go ahead with the VQ scan. After delivery, if the patient has already developed, because PE is very likely after the delivery of the baby mostly, so then in such scenarios, I can go ahead with chest X-ray, CTPA. Recommendation as stated, suspicion of PE in pregnancy warrants the formal diagnostic methods. D-dimer, this is a class 1. D-dimer assessment may be performed, but they has a negative value because they are also as a highly risk. So it's a class 2B. Venous compression also holds a class 2B recommendation in cases. Perfusion scintigraphy may be considered, and CT angio should be considered if the chest X-ray is abnormal only. They all hold the class 2 recommendation. A weight-adjusted dose of LMWH is a recommended therapy during pregnancy in patients without shock or hypotension, and it holds the class 1 indication. Anticoagulants, so LMWH is safe. UFH is also safe, unfractionated heparin, because it doesn't cross the placenta. Vitamin K antagonists, they have the risk of embryopathy, fetal hemorrhage, abruptions, CNS anomalies, so they are not indicated. NOACS are definitely non-recommended in pregnancy. So before moving further about the management, there is some points about the prophylaxis. How to prevent this VTE in patients who are critically ill and admitted in intensive care. The risk assessment we may divide in the medical patients or the surgical patients, and different scales or they have been improvised, namely the Padua scale, improved scale, Geneva scale on the medical patients, and the surgical scale, the Caprini scales. These are different scales and scoring system that help us to differentiate whether my patient need any prophylactic management for that. What are the prophylaxis management that I can choose upon? These are pharmacological or the mechanical or the combined. The pharmacological, as we have just discussed, they may be LMW, low molecular weight heparins, unfractionated heparins, FONDAPARINUX, and the mechanical that we can discuss intermittent pneumatic devices, graduated compression device, and a combination of both. Now, how to select them? It depends on my risk of thrombosis, my risk of bleeding, underlying comorbidities, institutional policy, preferences, and the values of the patient, the cost, obviously. Pharmacologic thromboprophylaxis. If the thromboprophylaxis depends on LMWH, UFH, and FONDAPARINUX. Now, these pharmacologic thromboprophylaxis are obviously they are superior to placebo or mechanical devices. In general, LMWH is obviously superior, but in acute neurological patients where there are chances of bleeding or in GI bleeding, UFH is considered much safer because unfractionated heparin has a shorter half-life and I can adjust it according to my needs more easily. Mechanical methods of thromboprophylaxis includes the DVT stockings and the intermittent pneumatic thrombosis device. They are used mostly in where there is high risk of bleeding, where pharmacologic anticoagulation is contraindicated, or the transition should from or just after the post-op patients, like cannot start off the pharmacologic thromboprophylaxis as soon as concerned because there is risk of bleeding. So I can go ahead with the mechanical methods of thromboprophylaxis. Contraindications are cellulitis, dermatitis, burns, ulcers, wounds, fragile vessels, ischemia, gangrene, among the others. How do they work? Evidence points to a reduction of DVT by compression stockings and the venous pumps in surgical patients, whereas little evidence has been found in the medical patients. There has been more evidence or points towards their use in post-op surgical patients. GCS, actually, this kind of compression stockings can lead to the skin complications. That's why their routine use in ICU is very questionable. So we mostly focus on therapeutic or the, not on therapeutic, sorry, pardon, on the pharmacological thromboprophylaxis in the critically ill patients. In the surgical patients, or there is any evidence of ongoing bleeding, then maybe we need to resort upon this mechanical thromboprophylaxis devices. Best is use a combined methods if the patient is too ill, who are at the highest risk of VTE. Maybe they have some more than one risk factors for there. Although there are a possessive of high quality studies comparing the combined methods to pharmacological prophylaxis, but data in general suggests that obviously combining methods would help me well. Mostly intermittent pneumatic compression device is a typical method used, but data comparing IPC and gradual compression stockings, they are very limited. So we can use either of them as per my patient need. These are my references. Thank you for your patient listening, and a happy Teachers' Day, because you have helped us for guiding and inspiring and making us what we are today. Thank you for your patience listening.
Yeah, thank you, Sudeshna. I think it was a very exhaustive and crisp presentation, encompassing all the important aspects of VTE management. Ghanshyam?
Thank you, Sudeshna.
Thank you, sir.
See, I think over the last many years, our understanding and the management of both VTE and pulmonary embolism has changed dramatically because of multiple reasons. One, diagnostically, I think we are better placed today because most of us are very comfortable using ultrasounds in the ICUs, and that is one of the easiest way of screening patients for DVT, and we all do that routinely. Second thing, I think we have a greater choice of anticoagulants available today, and the comfort of using thrombolytic agents is much better today. We have better thrombolytic agents, and since we are using thrombolysis in a large number of other settings like myocardial infarction, strokes, the comfort with which we use thrombolytics in pulmonary embolism is definitely much better. That's what I feel over the last many years. With respect to the placement of IVC filters as well, I think we are better placed today, and the ease with which a large number of centers have the facilities for placing IVC filters, especially in those patients where there is a contraindication for anticoagulation in documented DVTs, is significantly higher. Just want to add upon the concept of thrombolysis in two settings, which could be a little controversial. One is patients where you have documented PTE, but no hemodynamic compromise, but there is evidence of RB dysfunction with positive biomarkers. I think there's still a role for thrombolysis, especially when you individualize patients. Second, the role of low-dose thrombolysis, especially in those patients where the probability of bleeding is significantly high. I think there's a definitive role for both these in the management of patients with DVT and PTE.
True, true.
Yeah. So, what I can add is, just as we have seen paradigm shifts in the management of acute ischemic stroke. We have seen that the timelines have changed and the choice has changed. So the similar paradigm shifts have happened in the management of pulmonary thromboembolism, although we don't discuss that as aggressively as we discuss about stroke thrombolysis, stroke thrombectomy, and stenting. While stenting is maybe not an option in pulmonary thromboembolism, catheter-related thrombectomies, catheter-directed thrombolysis have all been attempted in pulmonary thromboembolism. So it is not that somebody has a massive embolism, we give up. With the availability of VA, ECMO, and VAD devices, temporary VADs, the outcome of patients even with massive PTE in shock has also improved. So an understanding of the pathophysiology of pulmonary thromboembolism and all the paradigms involved, the severity scoring, how to triage patients as has been so clearly described by Sudeshna. I think we should all have it in the back of our minds because we see it very often in the intensive care. So I think that's what I wanted to add. So next week, we will have a review about the Surviving Sepsis campaign and what is new with it by Dr. Ruby Patel from Zydus Hospital, Ahmedabad. Thank you very much. Join us again next week.
Okay.